Hi everyone, I hope you are doing well, and today we are discussing edema syndrome, which is very important and frequent condition in many diseases. Today we will cover basic terminology, we will revise blood content and another fluid contents, as well as pathogenesis of edema syndrome and many diseases like nephrotic syndrome, in which edema is part of this, as well as chronic heart failure, liver cirrhosis and other diseases, venous problem which has edema syndrome, and finally we will speak about drug-induced and latent edema syndrome. Let's start from basic terminology. What is edema syndrome? Edema syndrome, it is complex of symptoms which is characterized by fluid retention in the body with predominant accumulation in the extravascular space, with predominant clinical signs are peripheral edema and accumulation of fluid in body cavities. Peripheral edema, it is maybe local, asymmetrical, maybe generalized, symmetrical increase in any part of the body, fluid content due to increase of extravascular part of fluid there. Ascites, hydrothorax and hydropericardium, it is accumulation of excess fluid in serous cavities. Ascites is in abdominal cavity, hydrothorax is in pleural cavity, and hydropericardium is in pericardial cavity. Sometimes we can see hydroarthrosis when fluid is accumulated in joints. Anasarca, it is extreme edema syndrome which accompanied by massive generalized swelling of soft tissue in combination with fluid accumulation in serous cavities. And finally, latent edema. What is this? Latent edema, it is morphological and functional abnormalities of adipose and connective tissue because of fluid accumulation there without any clinical manifestations. And in the picture to the right you can see example of ascites when fluid is accumulated in cavity, in abdominal cavity. In this slide you can see scheme of body fluid content, and you can see that liquid in our body in adults has any 60 percentages, which is very high, and this fluid is distributed in some compartments. You probably remember from your previous courses that fluids is accumulated in intracellular fluids and extracellular fluids. Intracellular fluids, it is most amount, it is 2/3 of total fluid amount in our body, and extracellular fluid, has two parts, interstitial fluids and plasma. Interstitial fluids make 75 percentages and 25 percentages is our plasma. Its location you can see on the scheme in the left side. Between these compartments there is exchange, metabolism. For example, in extracellular fluid we can see capillary wall membrane. Between that fluids interact between plasma and interstitial fluid. And intracellular fluid, it is related by plasma cell membrane, and it is usually not severe metabolism with other compartments. 30 liters of plasma pass out of capillaries in day due into interstitial fluids, and then 27 liters is reabsorbed by capillary, and 3 liters of fluid is reabsorbed through the lymphatic system. In this scheme you can see explanation why this metabolism is possible. In arterial end of filtration you can see high hydrostatic pressure that is stimulate filtration process. When fluids goes out of capillary, it is happening near the arterial end of capillary because of capillary hydrostatic pressure is high. It is more than 10 milliliters hydrargyrums. Then mid capillary end of a vessel, it is condition when pressure is about 0, and this process may be two-side, in vessel and out of vessel, because no any movement near mid-capillary. And finally, in venous filtration, in venous end of vessel, in venous capillary, venulis and venule, we can find reabsorption process. Why? Because there is negative pressure of fluids, it is about -7, that means negative, and fluids go back intercapillary wall. This metabolism is constant and fluids re-enter capillary since capillary hydrostatic pressure is less than blood colloid osmotic pressure. That's why we can see constant exchange of fluids in the body, and this exchange may be damaged in case of some diseases accompanied by changes in hydrostatic and oncotic pressure. And we gradually move to next slide, in which you can see further explanation. Fluids flow only when there is a difference in pressure. This is first important conclusion from our previous scheme. Then, first, space shifting, normal distribution of fluid in both compartments, extracellular and intracellular. Second, space shifting, it is when excess accumulation of fluid is in interstitial area, it is edema. And third, space shifting, it is when fluid accumulates in area that normally have no or little amounts of fluids. Second situation is example edema. Third situation is example ascites, excessive process of accumulation. Role of arterioles in this process. Arterioles are arterial vessels which have intensive muscle wall. They may be diluted and they may be compressed very severe, they may be contractive. That's why in case of dilation of arterioles, we can see increase in capillary blood flow and capillary pressure is increased. When vessels are constricted, that means decrease in capillary pressure. This is mechanism of regulation for process metabolism of fluid. We also should remember about Bailey's effect or Bailey's law. In high BP, in increasing of blood pressure, arterioles are stretched with contract, and it is tendency to high pressure, to high blood flow. And venous pressure has another mechanism of regulation. In venous vessels there are no any muscle wall, and they, if they are increased in pressure, they are not regulated. Increasing pressure make increased capillary blood pressure, and non-changed venous are not changed this process. Let's discuss classification of edema. Depending on location, it may be generalized, which is a result of positive water balance throughout body, and develop in diseases of heart, kidneys, liver cirrhosis, chronic loss of potassium. And second, it may be local. Local edema, it is associated with fluid retention in certain area of the body. It is usually asymmetrical, and it is maybe due to mechanical damage as well as inflammation, allergic reaction, or impaired venous or lymphatic outflow. Next classification, which is the most important for us, it is based on pathogenesis, and we can distinguish 7 main points of classification. First of all, it is edema due to increased hydrostatic pressure, or it is venous pressure. Second possible cause, it is decreased oncotic pressure. Third is damage of capillary wall. Fourth is disturbance in metabolism of electrolytes and hormones. 5 is violation of lymphatic drainage. 6 is false swelling, and 7 is drug induced. Increased hydrostatic pressure may be due to heart failure, violations of venous outflow, and idiopathic edema. Decreased oncotic pressure is possible in case of nephrotic syndrome, diseases of liver parenchyma, enteropathy with increased protein loss, and cachexia. Damage of capillary walls may be because of disease like glomerulonephritis, inflammatory edema, allergic edema, hereditary angioedema, damage of nervous system. Disturbance in metabolism of electrolytes and hormones is possible in diseases like kidney diseases, premenstrual edema, hypokaliemia. Violations of lymphatic drainage may be primary and secondary. We will speak about it later. False swelling is mixed edema or, for example, systemic scleroderma. It is non-swelling, it is not edema, but swelling because of another causes. And drug-induced edema, it is because of some side effect of medications. In this slide you can see classification by pitting edema scale, classification by intensity. How to do it? You press on patient extremity and you can see intensity of fossa after your pitting. Pitting edema may be 4 degrees. In first grade, in first degree, it is fossa which is deep only 2 millimeters and it disappears immediately. It is mid-pitting and slight indentation, no perceptible swelling of area. In second grade, in second degree, it is maximum 4 millimeter and few seconds rebound. It is moderate pitting with indentation 4 millimeters and subsides rapidly. Grade 3, degree 3, it is 4-6 millimeters fossa and it is 10-12 seconds rebound. It is deep pitting, remains for a short time and area looks swollen. And grade 4 is when it is 6 and 8 millimeters and 20 seconds rebound and more. It is very deep pitting which lasts for a long time and area looks like very swollen. Let's discuss edema as a part of nephrotic syndrome. Nephrotic syndrome is a clinical and laboratory complex of symptoms which includes following signs: proteinuria more than 3.5 grams per day, hypoalbuminemia, albumin level is less than 35 gram per liter, hypoproteinemia when level of total protein is less than 60 gram per liter, edema, and sometimes we can find additional signs like hyperlipidemia, hypovolemia, hypocalcemia, and hypercoagulation. This is syndrome, it is not a disease. Syndrome, that's mean collection of symptoms, which we said right now, and it is possible to be in different diseases. Pathogenesis of nephrotic syndrome. In this scheme you can see possible, first of all, their structural and physico-chemical alteration in glomerular capillary wall. This problem leads to permeability to plasma proteins with heavy proteinuria, which leads to decreasing level of serum albumin, which leads to hypoalbuminemia. Finally, there is decreased osmotic colloid pressure. Colloid osmotic pressure is the same oncotic pressure, and it leads to decrease in plasma volume, decrease in glomerular filtration rate in kidney, and increased aldosterone secretion. In another sides, it leads to fluid accumulation in interstitial tissue, edema, or anasarca in advanced case, and finally this is explanation of edema development. In liver, what has happened in liver? In liver we have compensatory synthesis of some substance like lipoproteins, which are with increased catabolism give us picture of hyperlipidemia. Liver also produced albumin, but it fails to compensate because it is lost through kidney. Hyperlipidemia leads to leak through glomerular capillary wall and lipiduria. These are main components of pathogenesis of nephrotic syndrome. Let's explain how edema develops in nephrotic syndrome. As we said, in nephrotic syndrome there is massive proteinuria. This leads to hypoalbuminemia and decreased oncotic pressure, and it also leads to increased in enzyme working. For example, increased in sodium, potassium, ATFase, possibly other vasoactive agents, which leads to primary renal sodium and water retention and increase in capillary hydrostatic pressure. All these two processes leads to fluid move from intravascular to interstitial compartment, and here is two mechanisms which are possible to make edema. Underfill mechanism, because of decreased effective circulatory volume with secondary renal sodium retention, and maybe overfill mechanism, preserved to expanded circulatory volume, which finally leads to edema. Classification of nephrotic syndrome based on etiology. Nephrotic syndrome may be primary and secondary. Primary being a disease specific to the kidney, and secondary being a renal manifestation of systemic general illness. Examples of primary nephrotic syndromes are minimal change nephropathy or minimal change disease, which is very frequent in children and rare in adults. Next, focal glomerulosclerosis, membranous nephropathy, mesangial proliferative glomerulonephritis, and rapidly progressive glomerulonephritis. Secondary causes of nephrotic syndromes cover diabetes mellitus, lupus erythematosus, amyloidosis, paraproteinemias, as well as tumors, viral infection, preeclampsia. Let's talk about symptoms and signs of nephrotic syndrome. First of all, we can distinguish anorexia, malaise, puffy eyelids, retinal shin, abdominal pain, wasting of muscles, and edema. Edema is mobile. It is detected in eyelids, and when you palpate it, it is mobile. Movements is possible there. It is especially appear in the morning in patient and maybe in ankles after ambulation. Edema usually may be focal, may be generalized, and focal may be because of, for example, difficulty breathing in pleural effusion or laryngeal edema. Maybe substernal chest pain because of pericardial effusion. Maybe scrotal swelling, maybe swollen knees, hydroarthrosis, swollen abdomen, ascites, abdominal pain from the edema because of severe advanced ascites, and mesenterial area which is also swollen. In the scheme to the right you can see periorbital edema and puffy pale face, lips may be also swollen. In this photo you also can see patient having edema. In right photo it is patient before treatment, and in the left after treatment. Next signs which are possible in nephrotic syndrome, it is nutritional deficiency with protein malnutrition, myopathy, decreased calcium level with tetany signs, spontaneous peritonitis, opportunistic infections, coagulation disorders with decreased fibrinolytic activity, that means hypercoagulation. Next possible complication and sign is hypovolemia and risk of thrombosis, and maybe sometimes hypertension in cardiac and cerebral complications. Let's continue. So we said about nephrotic syndrome, and nephrotic syndrome may be three types of development. It may be episodic, recurrent, it may be persistent and progressive. Episodic, observed at the beginning of underlying disease with outcome in remission, and recurrent when relapses of nephrotic syndrome alternate with spontaneous or drug remissions. Spontaneous remissions are rare and cases of recovery are very rare. Most often it is observed with minimum changes of structure of internal organs. Kidney functions of this course remain normal for a long time. Next situation is persistent nephrotic syndrome, which is seen in 50% of cases, and that means nephrotic syndrome persists stubbornly for 5-8 years despite active therapy. This variant is noted in membranous glomerulonephritis, in mesangiocapillary glomerulonephritis, and many other types of chronic glomerulonephritis. After 10 years of onset of disease, usually chronic renal failure develops, and this is unfavorable for patient. And we have one more possible course of nephrotic syndrome. It is progressive or rapidly progressive, and the most unfavorable case when nephrotic syndrome progress during 3 years up to stage of chronic renal failure. It is maybe in 1/3 of patients, and it is observed in extracapillary type of glomerulonephritis and focal segmental glomerulosclerosis. This is the most unfavorable cause of nephrotic syndrome. How to treat nephrotic syndrome? Our aim here is to verify nephrotic syndrome and to recognize its cause for further treatment. In this scheme you can see how to distinguish patients with nephrotic syndrome. Have a look. So patient with edema came for doctor consultation. What doctor should do? He prescribed to do urine analysis and blood analysis. If in urine analysis he detect proteinuria, doctor should check selectivity of proteinuria. What is selectivity? Selectivity is what type of proteins are lost through kidney. It may be low selectivity and high selectivity. If high selectivity, that means only some proteins with very high molecular weights can be changed, and low molecular weight proteins, which is 9 or 10 and 100 units, 1000 units, they remain. In what type is worse, low or high selectivity? Low selectivity is worst because in this case many proteins are lost independently of molecular weight. If we found low molecular weight selectivity, this is bad, and we move to next analysis, blood analysis. We check protein level. It may be not changed, but usually it is low. Then we check proteinogram, in which we can detect albumin level is low, globulin level is low, and fibrinogen level is high. Then we check coagulation, in which we can find hypercoagulation, and we can check lipidogram. Usually total cholesterol may be high, and low density lipoproteins also high. This all corresponds nephrotic syndrome. Then we check it with clinical data, clinical symptoms for recognition of cause. Then we should check activity of disease, kidney function damage, presence of autoimmunity, and so on. And then we give final diagnosis. Does it primary or secondary nephrotic syndrome and main cause? Let's have a look on this slide, which describe possible clinical findings in nephrotic syndrome. Edema. As we said, it is mild, maybe varying severity from minimal peripheral to cavitary and anasarca. In skin we can detect erythema. Migratory erythema erysipelas without definite, it is typical for nephrotic crisis. We will speak what is nephrotic crisis soon. Then skin erythema may be localized in abdominal area with abdominal pain and maybe on the face in form of butterfly. This is typical for systemic lupus erythematosus and secondary nephrotic syndrome. Skin rash in decal area corresponds to systemic lupus erythematosus. Symmetrical skin rash on upper, lower extremities, torso, maybe in case of systemic diseases, vasculitis or systemic infections. Mucosal damage like enanthemas, cheilitis, stomatitis, typical for systemic diseases and secondary nephrotic syndrome. Articular syndrome in form of arthralgia without deformities, typical also for systemic diseases. Small joints of hands and deformity presence, this means rheumatoid arthritis present and subsequent amyloidosis in kidneys. If we check respiratory tract and can see bloody expectoration from the nose or bloody sputum, this is sign for systemic vasculitis. Violation of skin sensitivity, like decreasing sensitivity of skin, especially in upper and lower limbs, typical for diabetes mellitus and secondary nephrotic syndrome. Orthostatic hypotension, it is difference between sitting and standing blood pressure. It is also typical for diabetes mellitus. Enlarged lymph nodes of any localization, it is typical for oncological diseases with subsequent paraneoplastic neuropathias and nephropathia with nephrotic syndrome. In urine analysis, what should we check? We should check volume of urine, protein, selectivity, as well as urine sediments, presence of blood, and we can detect that protein in urine is high, especially albumin level present. We can check selectivity of proteins and fatty cast or oval fat bodies. These are major findings. In blood analysis, we can detect following changes. Peripheral blood examination or CBC sometimes can show us erythrocytes is decreased and hemoglobin is decreased. That means anemia, which is frequently develops in systemic diseases, oncological diseases, as well as glomerulonephritis and kidney diseases. Biochemical examination may reveal decrease in total protein level, albumin level, sometimes maybe decreasing of sodium, vitamin D and glomerular filtration rate. Sometimes we can find increase in urea and creatinine because of kidney involvement. Lipid examination can detect increase in total cholesterol level, low density and very low density lipoproteins, and stable high density lipoprotein. Coagulation test can reveal increase in fibrinogen and D-dimer and decrease in antithrombin and plasminogen factors. As we said, this is typical for hypercoagulation condition. Immunological test can help us to find decrease in IgG, immunoglobulin G, and other immunoglobulins and complements. Urine analysis in secondary nephrotic syndrome can help us to detect occult blood, which is typical for purpuranephritis or vasculitis, Ben-Jones protein, which is frequent and typical for paraproteinemia. In CBC, we can find pancytopenia or hemolytic anemia in lupus erythematosus, SLA, systemic lupus erythematosus with kidney involvement. In biochemical analysis, in case of diabetes mellitus, we can find high level of glucose, glycated hemoglobin, glycoalbumin. We can find high level of C-reactive protein and inflammatory markers in vasculitis, in purpuranephritis. We can find paraproteins in blood analysis, cryoglobulin, it is confirmed paraproteinemia. Next, lipid examination can additionally find increase in low-density lipoprotein, and it is confirmed glomerulopathy associated with some specific lipoproteins. Immunological examination in secondary nephrotic syndrome is very important because we can detect antibodies, anti-nuclear antibodies, anti-DNA antibodies, anti-phospholipid antibodies in systemic lupus erythematosus, complement level which is decreases. Sometimes we can detect positive bacterial culture in case of pathogenic microbes in blood. Laboratory findings we have done. Let's speak about instrumental examinations. In chest X-ray, we should check cardiothoracic ratio, pulmonary vascular shadow, angles of lungs and its shadows. We can detect pulmonary congestion. Congestion, that means that fluids is accumulated in pulmonary soft tissue, in interstitial space there. If we do renal biopsy, we may use methods of light microscopy and immunofluorescence microscopy, and definitive diagnosis is usually determined with these methods, but sometimes we need additionally electron microscopy by renal biopsy. This method is the most important for confirmation of primary cause of nephrotic syndrome, for confirmation of type glomerulonephritis. Finally, ultrasonography. This method is important for us because we can check with this method kidney structure changes, we can check low extremities venous condition, deep vein thrombosis, a collapse of venous system, thrombosis, and so on. Next, differential diagnosis of primary forms of nephrotic syndrome. Let's compare minimal change disease, mesangial type of glomerulonephritis, and focal segmental glomerulosclerosis. These are three the most frequent types of nephrotic syndrome, primary nephrotic syndrome. Incidence for minimal change disease, it is 85%, which is very high. Mesangial proliferation about 10%, and focal segmental glomerulosclerosis about 5%. Age of presentation for minimal change disease is about 5 years, it is child's. Mesangial proliferation 2 to 10 years, focal segmental glomerulosclerosis 2 to 10 years. Hypertension is not typical for minimal change diseases, it is only 10% seen. It is more typical for mesangial glomerulonephritis, up to 45%, and the most typical for focal glomerular sclerosis, about 50%. Hematuria is present in 20 cases of minimal change diseases and up to 90 cases mesangial glomerulonephritis, as well as 80 cases focal segmental glomerulosclerosis. Response to prednisolone. This is also important marker of favorable prognosis. Prednisolone is main drug for treatment, and some patients may give good response and recovery, whereas in other patients are not responded. So frequency of response to prednisolone in minimal change disease is 95%. Most patients have good prognosis here. In case of mesangial disease, mesangial glomerulonephritis, 60% give response, and focal segmental glomerulosclerosis give bad response, maximum 30%. Next, likelihood of maintaining renal function. 95% of patients with minimal change disease have this renal function is normal, whereas is mesangial type glomerulonephritis only 1/2 of patients, and focal segmental glomerulosclerosis 1/3 of patients. In light microscopy, we can see normal changes, no abnormalities in minimal change disease, increase in mesangial cells in case of mesangial type glomerulonephritis, and focal and segmental glomerular damage with hyalinization and sclerosis in disease called focal segmental glomerulosclerosis. Immunofluorescent microscopy can give us IgM, immunoglobulins, M deposits, complement deposits in mesangial proliferation, and also it is possible to be deposit in focal segmental glomerulosclerosis. Electron microscopy shows us in minimal change disease, it is fusion of food processes of podocytes. In mesangial proliferation, we can see increase in mesangial cells and matrix and small scattered electron dense deposits in mesangium. That means something is deposits in mesangium and give problem with kidney. In focal glomerular sclerosis, we can see many deposits, fine granular deposits in subendothelial regions. Now there is, you can see, differential diagnosis between nephrotic and nephritic syndrome. Nephritic syndrome example is acute nephritis, which is characterized by hematuria, edema, hypertension and oliguria, whereas nephrotic syndrome is characterized by heavy proteinuria, hypoalbuminemia, edema, hyperlipidemia. Acute nephritis in most cases is post-infective with immune complex deposition, whereas nephrotic syndrome is idiopathic. Acute nephritis usually has only one attack, whereas nephrotic syndrome relapse common. Then, immune complex deposition is typical for acute nephritis, and nephrotic syndrome is accompanied by retraction of epithelial foot process. In analysis in urine in acute nephritis, you can see albumin level is increased, hematuria is very typical, and RBC cast present. In blood, you can see increased urea and creatinine, it is raised. In nephrotic syndrome, another situation. In urine, there is never hematuria and no RBC, but proteinuria is very high and usually selective. In blood, urea creatinine ratio is normal. Let's move to next, edema in chronic heart disease. It is edema on the lower extremities with Dauchi consistency. When pressed, a pitting edema remains. This edema increase develops gradually. Usually it is symmetrical, it is non-displaceable, non-mobile, whereas in nephrotic syndrome it is intensifies in the evening. There is a pronounced dependence of edema on the position of body. That means that when patient is lie, his edema increase on back side. When patient stand for long time, edema increase in lower extremities. Localization on the lower extremities in walking patients, as I said, or lower back in bedridden patients. The skin over edema area is cyanotic. The development of edema is preceded by shortness of breath during examination. Congestion in lungs is often present in this case. With prolonged existence of edema, trophic changes of skin, maybe dermatitis occur, and in severe cases, visible edema is combined with hydrothorax, hydropericardium. Let's discuss ascites. Ascites is main manifestations of liver cirrhosis. Causes of ascites are possible. Cirrhosis of liver in 80% cases. Oncology up to 10% cases. Chronic heart failure sometimes just 7%, and other reasons which are very rare, like Budd-Chiari disease, gynecological diseases, peritonitis, parasites, vasculitis. Main problem in ascites is accumulation of fluid in peritoneal abdominal cavity. This is ascites. And now have a look on table of differential diagnosis in edema syndrome. We will compare nephrotic syndrome, liver cirrhosis and congestive heart failure. The onset of nephrotic syndrome is following. Edema appear on face. Firstly, if you remember, puffy eyelids are typical. Then it is appear in lids, maybe after some days or weeks. May take an undulating course with episodes of spontaneous convergence of edema. In liver cirrhosis, it is gradual appearance of ascites. In heart failure, it is gradual increase of edema in lower extremities for many months and for many years. Patient compliance with nephrotic syndrome will be, first of all, it is appearance of edema. In liver cirrhosis, complaints will be in increase of volume of abdomen, bleeding gums. In chronic heart failure, main signs, main complaints will be shortness of breath, fatigue. In anamnesis of patients with nephrotic syndrome, we may find hypothermia, taking non-steroid anti-inflammatory drugs or some drugs, penicillamine, antibiotics, gold preparations, vaccination. All these factors may cause damage to the kidney and cause nephrotic syndrome. In liver cirrhosis, we can find in anamnesis viral hepatitis, especially hepatitis B, hepatitis C, or alcohol abusing. In congestive heart failure, there is long-term hypertension, coronary artery disease in anamnesis, infarction of myocardium, stroke. Character of edema in nephrotic syndrome, it is soft, maybe minimal, latent, maybe up to anasarca. It is easily moving depending on the position of the body. In liver cirrhosis, edema predominantly is in form of ascites. In congestive heart failure, edema is dense in the lower extremities with trophic changes in the skin. Heredity factors in nephrotic syndrome and liver syndrome are not typical, whereas in chronic heart failure it may be burdened by hypertension, diabetes, obesity, or cases of sudden cardiac death in anamnesis in family. Proteinuria level is very high in nephrotic syndrome, more than 3.5 grams per day. Non-typical for liver cirrhosis and may be minimal to nephrotic level in heart failure. Hyperazotemia. This is a manifestation may be transient against the background of nephrotic activity, nephrotic syndrome activity, increases depending on disease duration. In liver cirrhosis, it is maybe with the development of hepatorenal syndrome and often pre-renal type. In heart failure, it depends on disease duration and moment of diagnosis. Sometimes may be underlying chronic kidney diseases. In biochemical blood analysis, in patients with nephrotic syndrome, we can find hypoproteinemia, hypoalbuminemia, hypercholesterolemia. In liver cirrhosis, we can detect also hypoproteinemia and hypoalbuminemia, but also hyperenzymemia is possible, like ALT, AST. ALT is alanine aminotransferase, AST is asparagine aminotransferase, and also one enzyme gamma-glutamine transpeptidase. Then we can detect high bilirubin level is possible. In chronic heart failure, we can see hypercholesterolemia, high level of total cholesterol, lipids level, dyslipidemia changes because of atherosclerosis. In CBC analysis, we can see in nephrotic syndrome, ESR is accelerated, autoimmune disease may give anemia, thrombocytopenia, and leukopenia. In liver cirrhosis, we usually see only thrombocytopenia. In chronic heart failure, we can see blood clotting, increased hematocrit, decreased ESR. In coagulogram, we can see tendency to hypercoagulability in nephrotic syndrome. In liver cirrhosis, we can see hypocoagulation and tendency to bleeding, and usually it is not changed in chronic heart failure. ECG changes. ECG in nephrotic syndrome are not typical, as well as in liver cirrhosis, but very informative for congestive heart failure, because we can see decreased ejection fraction, less than 60%, with diastolic dysfunction, signs of left ventricular failure. And ECG also, as well as echocardiography, are typical for congestive heart failure and shows us signs of left side hypertrophy. We can see hypertrophy of left ventricle using echocardiography, using ECG. We can see myocardial infarction in anamnesis, in ECG and electrocardiography. And ejection fraction, it is indicator of heart failure, which is seen in echocardiography. In differential diagnosis of ascites, it is important to know that ascites in heart diseases does not occur without a hemodynamic cause, like tricuspid valve insufficiency, stenosis, or compressive pericarditis, large pericardial effusion. A woman with ascites should be also examined with gynecologist. And we move to lymphatic edema, lymphostasis, lymphedema. Mainly causes of lymphedema are inflammatory, which are maybe specific like tuberculosis, filariasis, and maybe non-specific streptococcal infections. Next causes are non-inflammatory, like iatrogenic postoperative changes, for example after radial oncological operations, with operations unrelated with removal of lymphatic structures, post-radiation, maybe post-traumatic damage of lymphatic tract, burns, frostbite, fractures of limb, extensive damage to soft tissue, positional ischemia syndrome. Finally, it may be tumor compression of lymphatic tract. This leads to edema, and characteristics of lymphedema are following. Edema may be unilateral at first, and then both limbs are involved in the process. The asymmetry of edema is preserved even with bilateral lesions. In the stage of lymphedema, in first stage, edema is soft, non-permanent, pasty consistency when pressed, and pitting edema disappear. So lymphedema, it is non-pitting edema. In the transitional stage, it is next stage of development of this type edema. It is distal parts to the limbs become thickened, skin thickens, does not move well, and when pressed, pitting edema never appear. Total tissue fibrosis develops into final fibrodemic stage. With progression, we can see hyperkeratosis, papillomatosis, proliferation of tissue in the form of shapeless bumps separated by deep folds. With a long course of dermatitis, trophic ulcers develop. In this slide, you can see stammer sign, which is positive in lymphedema. You can see fold of skin at base of second toe, which can be gently pitched and lifted in case of negative stammer signs, and it cannot be pinched and lifted in case of non-pitting edema, lymphedema. This is an inability to tend the skin in lymphedema's skin fold. Very typical sign for lymphedema. And lymphedema has some stages. You can see on the picture two stages which are not severe and two stages which are very severe with irreversible changes. Firstly, lymphedema is asymmetric, in which the lymphatic system experiences abnormal flow but no fluid build up. Next stage is swelling due to accumulation of lymph fluid that may subside with elevated. Then, next stage number 3, it is permanent swelling that cannot be relieved through elevation, accompanied by changes in the skin and development of fibrosis. And final stage, it is lymphostatic elephantiasis. It is deformation of lymph which is irreversible due to extensive swelling, skin thickening and scarring. Let's discuss edema in deep vein thrombosis. Deep vein thrombosis, it is a type of venous thrombosis involving formation of blood clot in deep vein, most commonly in legs and pelvis. The mechanism behind formation of deep vein thrombosis typically involves some combination of decreased blood flow, increased tendency to clot, changes of blood vessel wall, and inflammation. What are risk factors? They are recent surgery, older age, cancer, obesity, infection, especially chronic infection, inflammatory diseases, antiphospholipid syndrome, personal history and family history of previous diseases of vein, trauma, injuries, lack of movement, immobility for long time, like in strokes or in post-operation period, and pregnancy. In diagnostic, people who suspected of having deep vein thrombosis can be assessed using a prediction rule such as Wells score or Wells criteria. Then we also use D-dimer test. It is laboratory marker which is used and increased in deep vein thrombosis, and diagnosis most commonly confirmed by ultrasonography, when we can visualize structures of vein and find corresponding thromb. Characteristic of edema in this case, it is local, unilateral, one side in the limb with pain, swelling. It is non-pitting edema. Extremity is red, enlarged veins are present in affected limb. In this slide you can see Wells score or Wells criteria for estimating deep vein thrombosis. It covers some clinical signs like cancer, paralysis, paresis, immobility for long time, tenderness along the distribution of deep venous system, entire leg swollen, pitting edema, and so on. And every clinical feature is given some score, and then we sum of total score and make conclusion about risk, does it deep vein thrombosis or not. Let's discuss edema in post-thrombotic syndrome. Post-thrombotic syndrome is also called post-phlebitic syndrome or venous stress disorders in a medical condition that may be a long-term complication of deep vein thrombosis. It is accompanied by pain, itching and cramping, heaviness, itching, swelling, edema, varicose vein and on background, brownish or reddish skin discoloration, and trophic ulcer formation. These signs and symptoms may vary among patients and over time, but mainly should be in anamnesis deep vein thrombosis, and these symptoms usually develops after some months and present for long time. They may increase after walking or standing for long time and improve with resting or elevating of the legs. When physician finds deep vein thrombosis in clinical history of his patient, he may suspect this problem, this post-thrombotic syndrome. For confirmation this, we use ultrasonography method. We must perform to evaluate situation, degree of obstruction by clots, location of these clots, detection of deep or superficial venous insufficiency. Since signs and symptoms may be quite similar, diagnostic should be delayed for 3-6 months after deep vein thrombosis, so an appropriate diagnosis can be made. Next possible problem is edema in varicose veins. Varicose veins are also known as varicose. It is a medical condition in which superficial veins become enlarged, twisted, and this veins problem typically develops in legs just under the skin. They are more common in women than in men, and they are linked with heredity. Other related factors are pregnancy, obesity, menopause, aging, prolonged standing, leg injury, and abdominal straining. Varicose vein has several signs like itching, heavy legs, appearance of spider veins, which called teleangioectasia in affected leg, ankle swelling, brownish discoloration if varicose vein present for long time, maybe redness, dryness and itchiness of area of skin, muscle cramps when making sudden movements, abnormal bleeding or healing time for injuries in affected area. Lipodermatosclerosis also can be seen in the ankles, near ankles. These patients having varicose vein may have high D-dimer level due to chronic level thrombosis with dilated vein. So D-dimer is increased in case of thrombosis, not in chronic varicose vein disease, but in case of thrombosis it is elevated. How to diagnose varicose vein? We have some methods for physical examination and we have also instrumental method. Physical examination is test called Trendelenburg test. With the patient in the supine position, the leg is flexed at the hip and raised above heart level. The veins will be empty due to gravity or with the assistance of examiner hands squeezing blood towards the heart. And then torreinment is when applied around the upper thigh to compress superficial veins, but not too severe to occlude deep vein. And then leg is lowered by asking patient to stand. And normally superficial saphenous vein will fill from below 32nd time as blood from the capillary beds reaches the veins. If problem present, we can conclude about communicating vein problems or deep vein problem, depend on what level incompetence to feeling well. After 22nd, if there is no rapid feeling, taurine is released, and if there is sudden feeling at this moment, it indicates that deep and communicating veins are competent, but superficial veins are not competent. Next method for diagnostic is ultrasonography. This is instrumental method which can visualize damaged veins, and it is typical for varicose vein, and this method is very used. Traditionally, varicose veins were investigated using another imaging technique, but now ultrasonography is routine method. Let's move to edema in chronic venous insufficiency. Chronic venous insufficiency, it is outcome. It is medical condition of many vein problems like varicose vein, like thrombosis and so on. And the most common cause is superficial venous reflux. Reflux is bad backflow of blood. As functional venous valves are required to provide for efficient blood return from the lower extremities, this condition typically affects the legs. If the impaired vein function causes significant symptoms such as swelling and ulceration, it is referred to as chronic venous disease. This condition is higher in women than in men, and other risk factors are genetic predisposition, obesity, smoking, pregnancy, and prolonged standing. Signs and symptoms of this condition are varicose vein in background, itching, pruritus, hyperpigmentation with brown discoloration of skin, phlebitic lymphedema in anamnesis, chronic swelling of legs and ankles, and venous ulceration. The most common cause, as we said, it is reflux. Reflux is backflow of the venous because of insufficiency of venous valve in superficial veins. It may be in turn to be caused by several conditions: deep vein thrombosis in anamnesis, superficial vein thrombosis, phlebitis, and sometimes diseases like May-Turner syndrome or another rare conditions with some genetic predisposition. History and examination by a clinician for characteristic signs are sufficient in many cases in ruling out systemic causes of venous hypertension. And methods for precise diagnostic is ultrasonography, especially Doppler ultrasonography, which can show us blood flow direction in precise area. And we move to drug-induced edema. What drugs can cause edema? Some hypotensive drugs like calcium channel blocker, beta blocker, clonidine, they can give us side effect with edema. Next group of drugs is non-steroid anti-inflammatory drugs like ibuprofen, celecoxib. They also can cause edema. Then antiviral drugs acyclovir, hormones, androgen, corticosteroids, estrogen, progesterone, testosterone. These drugs, hormones, can give and frequently give edema syndrome. Then, antidepressants may give us edema syndrome. For example, monoamine deoxidase inhibitor or trazodone. Next, chemotherapy drugs, cyclophosphamide, cyclosporine, and other cytotoxic therapy can give us edema. And sometimes cytokine drugs, this is biological therapy which is used in systemic diseases, also can cause edema. For example, interferons, interleukins drugs, and so on. And we move to latent edema. What is this condition? As we said, latent edema, it is changes in structure and function in morphology of internal organs because of fluid accumulation, and no clinical signs at this moment. How to diagnose latent edema? Peripheral edema becomes noticeable after increase in amount of fluid in interstitial tissue by 5-7 liters. This is preceded by latent edema or fluid retention, which can only be detected by indirect methods. For example, we can measure constantly patient's weight and compare its in dynamic. If it is increased, gradually increased, it is also maybe signs for latent edema. If patient have any predisposing conditions, we should be attentive for latent edema. Conclusion. Quality and life expectancy of patients with edema syndrome, as well as their social adaptation, are determined by timely diagnosis and adequate appointment of appropriate therapy. As we understood, many diseases can cause edema, and many problems for differentiation are possible for clinicians. That's why we should pay attention to edema syndrome. We should study well its symptoms, possible causes, and the prevalence of edematous syndrome. Possibility of its manifestations in number of diseases demonstrates the importance of knowledge for differential diagnostic. Thank you so much for this lecture.